Hello, my name is Kathleen Lisson. I am a lymphedema therapist from the United States of America, and I am attending the V Italy 2025 Rome Vein Lymphatic Global Summit. And I am doing a recap of the things that I heard in day two and day three. So that's kind of like our vein week. In day two and day three, I took my notes and I am sharing them with you. So day two was it was like a tour of the world and different experts from around the world talking about the different topics. So from Czech, we heard the concept of we can know the job, but who will pay for it? And that's that very important understanding that we can encourage and give out as much education and become educated as experts ourselves. But if the insurance isn't covering the surgeries that they are training for, they're not going to be able to make as big of an impact no matter how much education they have. So insurance and getting insurance to cover treatments is a major part of getting the services to the patients that need them. An expert in Caribbean talked about their programs, and they have an extremely high level of compliance with compression, which stunned me. It was in the 70s as far as percentage of people who are complying with compression. So I got up on the mic and said, "How are you doing this? This is amazing." And they said, it was interesting to us to see that statistic as well. But what they do is they do class one stockings. So they are starting everyone in a lower level of compression, which will get them used to it so they are more compliant with it. And they will also show graphic photos of what happens if you don't use compression and you have the conditions that they have. So it's the combination of the stocking is more comfortable and the graphic photos really showing them visually why they're wearing that stocking every day. In Egypt, our colleagues in Egypt are utilizing their natural water sources of saline-rich pools. So they have different types of natural water pools in Egypt, and they are utilizing them potentially as part of lymphedema therapy. So if you're going to be doing exercise, the question is that exercise even more beneficial if it's done in these special naturally occurring saltwater pools? So very interesting to see research that comes out from that concept. And that might make it a very attractive place to go and take a vacation that is also giving you some decongestive therapy to take some treatment while you're there at the clinic and then do the exercise in that pool if you needed decongestive therapy and wanted to visit a fantastic, beautiful, and very historic destination in Egypt. In the Netherlands, we had a rich conversation about different feelings of if the client refuses compression, do you still continue lymphatic treatment for them? And some people were saying you need to give the clients choice points. They need to be able to choose what they do. And other experts were saying, we mandate this, you must use compression if you're going to get the formal treatment. To one of our colleagues even saying, I have a signed document that they have to look, they have to understand completely what we're going to do before we do it and sign the document. Not that it's legally binding, but that this is how we are taking it seriously. And if you're not following your half of the bargain, we're not going to continue with the treatment. And then we also talked about the importance of all care team members, all members of the care team, if there's a multidisciplinary care team, have to have the same unified message, have to be following the same unified protocol. So wherever the client sees that information, it has to be the same throughout. You can't have one person saying one message to them, another person saying another message. And then the idea that at the national level, there should be a central place for valid information, no myths, but like evidence-based valid information that people can access to know that there's trusted information that they can rely on when they have questions about their disease and its treatment protocol. Okay, so that was day two. It was a little bit of a short day. Then day three today was the full long day. And we talked a lot about lipedema and a lot about lymphedema. So let's look into some. Actually, let me start with the stuff that's not lipedema, and then we'll be able to do all the lipedema stuff at the end. So I really learned a lot about pelvic venous disorders. So the symptoms are like heaviness at the end of the day, pain with urination, pelvic pain. And this I've heard at series of conferences. We always get this information on pelvic venous disorder. It was great to get it at a like a vein conference. So they were really talking about it. And the idea is you have to get the information out because I think it's not very well known, the pelvic vein disorder symptoms, and how do you coordinate? So this was their internal conversation as the vein experts. How do you coordinate getting the OBGYN to see it and then getting the OBGYN to get them to a venous professional to get the proper diagnosis of it and then the treatment? Okay, and then there was a talk about, and this is specifically veins. They will use foam as a sclerosant, and they actually had a medical physicist there talking about asking questions about the foam. So I think this is the widest variety of experts that I've seen in the last couple conferences I've been to. I'm always very happy to see how we're widening out the experts. It's not just a bunch of the same lymphedema therapists all talking to one another, but I've seen now there's the vein and lymphology people coming together. And at the conference in LA, we were seeing people from many specialties, and then many parts of the client's care team were talking. I've seen presentations by interventional radiologists at other conferences, but this one was a fantastic new one for me. An actual medical physicist was coming and having a conversation with the vein surgeons about their foams. And I love the turn of phrase that the speaker on Verathena used. He talked about taming a lion with a piece of cake. And I love these very colorful because it rivets your attention and you instantly understand viscerally the situation that you're in. And then he talked about then if things get worse, it's like the lion is now turning into a dragon. So I love using those colorful turns of phrases to really highlight the difficulty of what you're trying to do and the intricacy and the talent and expertise that it takes to do it. So now let's just dive in because I think the rest of the stuff is all about lipedema, and we talked about it in many, many of the presentations today. We talked about one of the commenters shared information on the idea that we all know that lipedema is the people are not diabetic. At the same rate as people in the general population with matching things. But the idea was like, but we have to not just stop at looking at diagnosed diabetes. We have to look at the insulin levels and what is happening to the insulin levels. Like we have to look at what is happening at the hormone levels because these changes in hormones levels of women are when you will see the lipedema get worse. There was a very interesting, I wrote it down. I'm not sure how I'm going to be able to find out any facts behind it. But someone stated that the blood capillaries don't evolve in lipedema, which I'd definitely like to ask. I have to pull somebody aside, a colleague of mine, and ask exactly what that means and what that might mean for the disease. Okay, and then Dr. Roxon had a great presentation, and he stated that the reason what and there's so much research out. I am absolutely in awe of the amount of research that we've seen in the past 10 years on lipedema, especially the past 5 years. But there could be more answers, and the answers aren't coming as fast as we need them to because there is no animal model for lipedema. We know we have like a mouse model for lymphedema we can reliably make, lymphedema in a mouse tail, but we cannot have an animal model to do testing and get ideas from that research. We are 100% relying on human tissue and human experiences because we can't find an animal that has lipedema that we can do experiments on. And something that we know, but I wrote down that it's important to always keep in hand in your brain that the dietary changes for lipedema can reduce the symptoms independent of weight loss. So if someone changes the foods that they eat to reduce the inflammation, they can have changes and reductions in the severity of their lipedema symptoms before and not connected directly to losing weight on a scale. So it's not just about the scale, it's about the way the food is interacting with the body. There are lymphoscintigraphy changes in lipedema. There's histology identical to lipodermatosclerosis, which is very interesting. This was part of the Dr. Roxon's speech. There's capillary permeability, and the capillary permeability is what is causing the orthostatic edema. So a lot of times you'll hear that there's two things. There's a contention in the different standards of care about whether pain should be a mandatory symptom, and then there's contention about whether there is a change in the lymphatic system with lipedema. And we see here from Dr. Roxon's presentation that it's the permeability of the capillaries that is causing orthostatic edema. That's one way that you are seeing edema in lipedema. In late stage, you will see increased lymphatic waste, reduced transport volume, lymphangiosclerosis, and perilymphovascular fibrosis. Then we talked about, this was a separate, so aside from Dr. Roxon, we had other experts talking about lipedema, and we saw that you should treat the veins. Oh, this is lymphedema. Okay. So Dr. Roxon, yeah, let's go back to just Dr. Roxon's presentation. So lymphedema, I asked him in a question about the drugs that he is looking at, and then about GLP-1 agonists, and he said we haven't seen much of a change with the GLP-1 agonists for people with lipedema taking them. Not as big as we'd obviously want to. And then the lipedema drug that he had a very, very small trial, and he's seeing from that trial a reduction in symptoms in the participants of that trial who took that drug. So that's something we'll definitely keep our eye on. And then for this lymphatic surgery, I was the person that gave the response to a presentation on lymphatic surgery. And so this is for lymphedema. So we're moving away from lipedema to lymphedema. So for lymphatic surgery, the surgeon stated that they recommended to treat the veins before the lymphatic surgery because you need good veins to put those LVAs into the vein. So we're anastomosing, the doctor is anastomosing the lymphatics to the veins. And I asked him to share information about the improvements in quality of life and the reduction of cellulitis. So if people are having lymphatics, this microsurgery, super microsurgery, they are seeing a reduction in the incidence of their cellulitis episodes. And that's where the real financial burden comes with the disease, is if someone has repeated bouts of cellulitis. So I think that's very important to understand. It's not just we're going to do this surgery so your arm gets smaller. It's we're going to do this surgery to improve your quality of life, to potentially reduce your episodes of cellulitis. It doesn't have to just be a measuring tape surgery. And we also talked about the importance of, or I specifically said in my comment that it's not a failure surgery. It's not a last ditch surgery. We have to deliver people with lipedema to these surgeons earlier. It shouldn't just be a last ditch effort because you can make more of an impact in a client whose lymphatic system is less damaged. And I know that's not what we're seeing with the insurance coverage, but that would be the best. It's not you have to fail conservative therapy and then and only then do you see a lymphatic surgeon. I know that is not an opinion that's shared currently by a lot of insurance companies. So, but I think that is what is best for the patients. So that is my day 2 and 3 notes. We have 1 day left, so you'll get another video out of me in the next couple days. And let me know in the comment section wherever you see this, any of your questions, any of your ideas, any of your reactions to all of this, because I'm doing this so I can look at this information a second time to kind of get it in my brain, but I'm also doing it because I know that not all of us can go to this conference, but I want all of us to be able to benefit from the ideas that are shared in this conference. So thank you and have a great day, and I look forward to reading your comments.